Hello everyone. Today we will continue our lecture about anti-seizure drugs or anti-epileptic drugs. This is a second session. In the first session, we already discussed the definition of epilepsy, the definition of anti-seizures, and the definition of convulsions. And in this session today, the second part, we are going to discuss the treatment approach and drug information. We are going to discuss individual drugs. What is the advantages, disadvantages, and and differentiate between a group of medication or a group of drugs according to the site of action, mechanism of action for each drug. Okay, as you can see from this picture here, we have several groups involved in the treatment of epilepsy or seizures. The most popular one we have like phenobarbital, benzodiazepine, topiramate, followed by the this group of medication work on GABA. Another group of medication, Phenytoin, Carbamazepine, Lamotrigine, Topiramate. This group of medication work on the sodium channel and the glutamate neurons. Then we have Ethosuximide, Topiramate, Valproic acid work on the calcium channel, T-type calcium channels. We have Levetiracetam, Keppra, inhibit the SV2A protein on the glutamate vesicles. We have the last two medication and the list here is in the practice, the Tegretol work on the transport, and then the GABA GA transport. Then we have Gabapentin, inhibit the enzyme called GABA transaminase, and the last one here we have Fulbamate inhibit NMDA. And if you look on the highlight here, what we have for the highlight, someone may ask, what about this highlight medication? Is mentioned in 4 site. You can see here Topiramate work on the GABA. Topiramate inhibit T-type calcium channel. Topiramate inhibit sodium channel AMPA receptor. Topiramate inhibits sodium channel on the presynaptic receptor and the presynaptic sodium channel. So you can see here Topiramate work on several places. For this reason, Topiramate considered like broad spectrum and could be used for treatment like all type of seizure. Okay. What is the treatment approach, the treatment goals of therapy here? Before we start treatment, we need to identify the cause and type of epilepsy. So number one, identify epilepsy syndrome and what type do you have according to the clinical evaluation and neurological exam and EEG. So here we have some steps before you start and decide to go the treatment. If you decide to go, you diagnose the case like epilepsy syndrome, what we are going to do, we start normally with a monotherapy. We start with one drug, and this single medication, we start with the lowest effective dose here. So in this case here, we expect the prescriber, the physician, the nurse, the physician assistant to be familiar with what is the lowest therapeutic dose for the medication. Then with the lowest therapeutic dose, we start increase the dose for the patient. Okay, we start increase the dose until we get the response. So when you get the response, so you can see here, push the drug to the efficacy or side effect. So if you get the response here, that's great. This is number one. And another option here, no response, but we are having some side effect. Okay, so this is the first one. Start with the one medication, monotherapy, and push the medication to the efficacy. Or if you don't have efficacy, push the medication until you see some side effect or adverse effect. Okay, in this case, if this drug failed, if the first drug fails, we change to another drug, to the second drug. The same situation, the second drug push to the efficacy or side effect. If they fail, we move to the third medication. So as you can see here, we start with the monotherapy. If the monotherapy fail, move to the second drug. If the second drug fail, move to the third drug. If the third drug fail, we can maybe consider combination treatment of 2 or 3 medication. So you can see in the beginning monotherapy, then move to the second option, third option. If not, if this maybe attempt is not effective, we move to the combination therapy according to the EEG monitoring. Okay, we start with the first medication in the group here, as you can see. Okay, the first medication on the list for and the popular medication prototype for anti-epilepsy or anti-seizure drugs, as you can see here in the graph, we have Phenytoin, Dilantin, and we have the list of variables here. We need to understand how this medication work, mechanism of action, what is the therapeutic use for this medication, any concern about adverse drug reaction, warning, precaution, and the drug interaction. DI stands for drug interaction. Then if we have any comment, we can address that. Start with the beginning here. We have Phenytoin, Dilantin, how this medication work. This medication block sodium channel. Okay, we have the brand name here, Dilantin or Dilantin. This medication used for treatment of tonic-clonic seizure. You can see it here, tonic-clonic seizure, general tonic-clonic seizure, prevention and treatment of seizure due to the neurosurgery. The patient will go, for example, need to go to the neurosurgery, and we can prescribe Phenytoin to prevent a seizure, or if the seizure happened after surgery, we can prescribe Phenytoin. Also, we need to remember that Phenytoin is like a block sodium channel, and the sodium channel not only available in the brain, we know that a sodium channel available in the heart. For this reason, if you go back to the cardiac arrhythmia pharmacology, clinical pharmacology, you remember that Phenytoin belong to the 1B class of antiarrhythmic drugs. So you can mention here the receptor for Phenytoin available, or the channel will be affected by Phenytoin will be available in the heart and in the brain. Okay, the Phenytoin used for general tonic-clonic epilepsy, prevention and treatment of seizure during neurosurgery, and consider like the class 1B as antiarrhythmic drugs. Moving to some adverse effect, the patient may suffer from nystagmus, ataxia. This medication induce metabolism. For this reason here, this medication will accelerate metabolism of folic acid. So this medication, Phenytoin, increase metabolism of folic acid, and the result will be megaloblastic anemia. For this reason here, we recommend patient who is taking the Phenytoin to take folic acid as a preventive therapy to prevent occurrence of metabolic megaloblastic anemia. Another maybe hallmark for the Phenytoin as side effect, Phenytoin may cause gingival hyperplasia, okay, lymphadenopathy, hirsutism. Phenytoin also not only increase metabolism of folic acid, increase metabolism of vitamin D, and this may increase risk of osteomalacia or osteoporosis. Phenytoin considered like teratogenic, cause the birth defect, and we have the syndrome called fetal hedontoin syndrome, and neural tube defect like spina bifida. So for this reason here, we don't recommend to use Phenytoin during pregnancy, and this is classified as D during pregnancy. Okay, classified D during pregnancy. This medication for Phenytoin, we need to remember this medication, when you place your patient on Phenytoin, you need to decrease the dose gradually, because if you stop the medication suddenly, the patient may suffer from status epilepticus. Some patient may suffer from suicidal behavior or ideation. We are going to discuss this last maybe point here is very important for us. But what about other option here? So for the Phenytoin, we have some other type of Phenytoin called Phosphenytoin. Phosphenytoin available like injection or water-soluble prodrugs, and will be converted to the Phenytoin in our body. They try to remind us Phenytoin used for tonic-clonic, for the some type of seizure during surgery, but it's not for the absence seizure. Okay, so we don't use it for absence seizure. You need to keep this one on your mind. Okay, Phenytoin, we're done with the Phenytoin. Okay, in this screen here from gingival hyperplasia hidradenitis, if you put it on, or if you place this search on the Google search and look on the image, you can see the gingival hyperplasia due to the treatment with the phenytoin. This number one, the side effect. Lymphadenopathy, you can see the lymphadenopathy in the neck here, could be the side effect of phenytoin. And the third one, you can see the spina bifida or like neural defect syndrome coming maybe as due to the treatment with the phenytoin. Okay. If you remember, we discussed the phenytoin considered like inducer. At the same time, we need to remember that phenytoin, number one, is two things about phenytoin. Number one, phenytoin considered like inducer. Number two, phenytoin considered like narrow therapeutic index. Okay. Okay, speaking about narrow therapeutic index, here we need to look what we have. So, for example, here we have, if you look on the graph here, for example, we have the drug concentration. Here we have minimum drug concentration. Here we have maximum drug concentration. And this is, we consider like this one here between the two lines. This is a concentration of the drugs considered like therapeutic drug. Monitoring or like narrow, we can call this one therapeutic window. I will go with this one, call it like therapeutic window. Okay, so from this one here, if you look, we have, this is a general one, for example, but we have some medications. If you click on the green one, we have some medication with the green one. For example, if you talk about minimum, we have, if you speak about phenytoin, and the phenytoin minimum concentration very close to the maximum concentration. So any change in the drug concentration between the minimum and maximum, this will lead, any change lead to the toxic effect, or if we clean this one here, this is a effect, and this is sub-therapeutic effect. So what happened here, any change in the drug concentration, so if the drug concentration, I will maybe keep it like, if the drug concentration increase, any change, small lead to the toxic effect. Okay, this is number one. Number two, if we have, for example, if we prescribe a lower dose to the patient, that means the dose will be here. So in this case, we are not going to see, there is no effect, no therapeutic effect. That means the patient will suffer from seizure. So it's very important to keep monitoring your patient and be sure the patient within the normal therapeutic range, and we have the value for this one. Okay, so in the practice, we need to be familiar with this one. Okay, so in this number one inducer, number two narrow therapeutic window, and this will lead to the something very important to call this one drug-drug interaction. Drug-drug interaction, that means this medication may be exposed to the a lot of drug-drug interaction. So you can see here from the slide, the phenytoin considered like inducers for hepatic microsomal enzyme, inducer, accelerate. So we can replace inducer with the accelerate metabolism of medication. For example, phenytoin accelerate metabolism of cortisone. Coumarin anticoagulant. For example, coumarin, one of the most important drug belongs to the coumarin. We have warfarin. So if this medication prescribed, warfarin prescribed with the phenytoin, so the situation will be, if this medication prescribed phenytoin, prescribed with a warfarin, that means phenytoin will accelerate metabolism of warfarin. This will lead to the decreased concentration of warfarin and decrease efficacy or effectiveness. When the warfarin efficacy decrease, the result will be increased risk of clotting. Could be stroke, could be heart failure. So we can see here the combination between phenytoin and warfarin. So if the patient on warfarin and come to the hospital suffer some seizure, and you as a maybe healthcare worker in the emergency room, you prescribe phenytoin to your patient, the phenytoin will accelerate metabolism of warfarin. You can see the 3+ here, decrease concentration of warfarin, decrease efficacy of warfarin, and there's a risk of clotting there. Okay. Moving to this number, maybe important example, the same applied with the estrogen. Here we are speaking about, for example, some oral contraceptive pregnancy may occur, for example. So for this reason, we have to be careful prescribing phenytoin with the oral contraceptive, and we have list of medication also here. We can discuss it. Okay, so you can see here what we have. Phenytoin and use accelerate metabolism of several medication, and we explain one of them, for example, warfarin, another one oral contraceptive, for example, and another digoxin, for example, in the list. What happened with the other medication? We have some medication may increase level of phenytoin. Some medication may increase level of phenytoin, and we know that. We already discussed that in this slide. We said that phenytoin has narrow therapeutic index. Any change in the concentration of phenytoin may increase the risk of toxicity, or there is no efficacy, not effective, become not effective medication. Amiodarone belong to the cardiac antiarrhythmic drugs. Chloramphenicol, cimetidine, one of the most popular medications, not popular in the practice, but cimetidine inhibit metabolism of phenytoin. This will lead to the increased level of phenytoin. Serum level of phenytoin will be above the optimal range, and this will lead to the toxicity of phenytoin. Patient may suffer from delirium, psychosis, encephalopathy, and this one will be irreversible cerebral dysfunction. And most of these information derived from sources. We recommend you to click on this link here and bring the information for yourself. So you can see here one of the, what else do you have here? For example, we have tolbutamide, we have sulfonamide, we have salicylic acid, we have methylphenidate, halothane. So list of medication, diazepam, decumarole. All these medication may interact with the phenytoin, dilantin, and lead to the increased level of phenytoin, and it goes like confusional states, delirium, psychosis, encephalopathy. Okay, the last one here regarding the interaction between the phenytoin and other medication. The most popular medication for us, carbamazepine. Normally we can see a patient on two medication, two drugs. These two drugs could be phenytoin plus carbamazepine. Okay, phenytoin and both of them for epilepsy. Phenytoin and carbamazepine. What they said there. So carbamazepine accelerate metabolism, induce metabolism of phenytoin. Accelerate metabolism, and this will lead to the decreased level of metabolism or decreased level of phenytoin and increased risk of epilepsy. So for this reason here you can see we don't recommend to combine phenytoin with the carbamazepine, because carbamazepine accelerate metabolism of phenytoin, decrease level of phenytoin, and increase risk of epilepsy. Okay, this maybe the second medication. As you can see here, we have Carbamazepine and the brand name Tegretol, and carbamazepine work on the similar mechanism, block sodium channel. Carbamazepine used for partial seizure, generalized tonic-clonic. The most important advantage for this medication, carbamazepine, this medication could be used for trigeminal neuralgia. So partial seizure, tonic-clonic, general anesthesia, general seizure, and the trigeminal neuralgia. This is a therapeutic use for the carbamazepine Tegretol. This medication may cause nystagmus, diplopia, ataxia, induced liver enzyme, increased metabolic of folic acid, cause megaloblastic anemia, teratogenic, increased ADH, cause hyperthermia and edema. This medication carry the risk of serious dermatologic reaction, aplastic anemia, granulocytosis, increased risk of suicidal thought or behavior. Tegretol is available like immediate and extended release tablet. Serious dermatological reaction with Tegretol, carbamazepine. Tegretol can cause severe and sometimes fatal skin reaction, such as toxic epidermal necrosis, TNF or TNN, or Steven Johnson syndrome. This happened 1 to 6 in 10,000 per 10,000 user of the Caucasian population. So carbamazepine may cause toxic effect, toxic epidermal necrosis or Steven Johnson syndrome, 1 to 6 per 10,000 new user. And they found that this side effect, dermatological side effect, popular in Caucasian population, especially about Chinese ancestry, and this one may be related to the ethnicity. So which of these anti-epileptic drugs has a high level of serious dermatological interaction symptoms or adverse reactions in Chinese population? We have carbamazepine due to the HLA-P1502 allele. Okay, moving to the screening recommendation. Here we have to do some genetic diagnosis before you prescribe this medication. Okay, again we have some drug-drug interaction here. Drug interaction, we need to look on this one. We have some medication inhibit the cytochrome 3A4. By inhibiting 3A4, the carbamazepine plasma level will be increased. So when the plasma level increases, there is a risk of toxicity here. Again, similar situation if you go back to the Phenytoin. If you increase level of carbamazepine, there is a risk of toxicity, because also carbamazepine considered like narrow therapeutic index medication. So any change in the concentration increase will be lead to the toxicity. Example of this medication inhibit 3A4, we have cimetidine, danazol, diltiazem, macrolide, clarithromycin, nafazodone, loratadine, niacinamide, fluconazole, acetazolamide, grapefruit juice, and valproic acid. These medications accelerate. Okay, moving to some medication that induce. This medication induce accelerate metabolism of phenytoin. This will lead to the decreased plasma concentration and increased risk of seizure. Okay, here we have increased risk of toxicity. Here we have decreased efficacy. Cisplatin, doxorubicin, felbamate, rivaroxaban, phenobarbital, phenytoin, and so on. So we need to take a drug history or medication history from the patient in order to be sure there is no risk of drug-drug interaction. Okay, drug agent affecting carbamazepine plasma level. Here we require to monitor the patient, close monitoring to the patient for carbamazepine level, and we need to adjust the doses to be sure we are in the same. We are in the therapeutic range of this medication, with the therapeutic window of this medication. Okay, Tegretol is contraindicated in patients taking nafazodone. Nafazodone antidepressant medication is not allowed to prescribe it with the Tegretol or carbamazepine. Tegretol is also considered like neurotoxic if you use it with the lithium, and lithium is a medication used for bipolar disorder. Tegretol also decrease the effectiveness of hormonal contraceptive, and there is a possibility of pregnancy. Okay, so you can see here we have a lot of drug-drug interaction, and maybe a lot of maybe consequences when you combine carbamazepine with a cytochrome 3A4 inhibitor or inducer, or we can use it with a nafazodone or with a hormonal contraceptive. Okay, here we have some medication that decrease plasma level. Tegretol decreases plasma level of. Here we speak about Tegretol, considered like inducer, accelerate metabolism of other medication. Okay, example for that, very important for us to remember. So carbamazepine accelerate metabolism of other medication, include acetaminophen, the brand name Tylenol, Ethosuximide, Lamotrigine, Phenytoin, Topiramate, Valproic acid. Carbamazepine and accelerate metabolism and decrease carbamazepine, Tegretol decrease plasma concentration of tricyclic antidepressant. Continue speaking about decreasing plasma concentration. We have midazolam, alprazolam, decrease plasma concentration because this medication accelerate metabolism of this medication, accelerate metabolism. The carbamazepine decrease concentration of tramadol, hormonal oral contraceptive, levothyroxine, cyclosporin, cortisone, warfarin, decrease concentration, decrease plasma concentration. So with the warfarin, there is a risk of glutting. If you use warfarin with the carbamazepine, similar what we have in the with the Phenytoin, there is an increased risk of glutting. Okay, next medication. So we already discussed Phenytoin, followed by carbamazepine. The third medication now, Valproic acid, Depakene. Valproic acid work on the mixed mechanism, considered like broad spectrum. For this reason here, valproic acid cover all type of seizure. Valproic acid inhibit GABA T, stand for transporter or transaminase, GABA transaminase, valproic acid. Valproic acid inhibits sodium channel in the preganglionic neurons, block calcium channel, valproic acid, okay, T-type calcium channel. So you can see here we have like multiplicity of action. Transport or transaminase, sorry, inhibit transaminase for GABA, block sodium channel, block calcium channel. Speaking about the valproic acid may cause alopecia, pancreatitis, hepatotoxicity, somnolence. For this reason, we don't recommend patient to drive or work on the machine. Suicidal thoughts or behavior, encephalopathy, hypothermia, drug reaction with eosinophilia and systemic symptoms. We call this one DRESS, DR, the drug reaction, eosinophilia, systemic symptoms, and could be involved in multi-organ hypersensitivity reaction. So here we can see the patient coming to the clinic suffer from multi-organ hypersensitivity reaction. On the other side, if you go back and remember the first two medication, and we spoke about the first two medication, I will go to the whiteboard there to show you what we have. We discussed that with you. I will use the red color. We discussed that Phenytoin and carbamazepine. Both of them considered inducer. Okay. On the other hand, we talk about valproic acid or valproate. Valproate considered inhibitor. Okay, valproate considered inhibitor here. I will go back to the slide again. Okay, so you can see here valproic acid inhibit the macrosomal enzyme. Okay, so what we need you to remember here, the multiplicity of action: sodium, calcium, transaminase, GABA transaminase. Valproic acid cause alopecia. If you go back to the phenytoin, you can see the phenytoin cause hirsutism. Okay, so you have now anti-epileptic drugs. One of them cause hirsutism, phenytoin. Another one cause alopecia. Is available like liquid or syrup for children or elderly people unable to take tablet or capsule or solid form. Okay, for the valproic acid. Used for all type of seizure. What else? We need to remember that this valproic acid Depakene considered a high risk of congenital malformation. Consider like this medication may cause teratogenic. This medication considered X in pregnancy, teratogenic medication. So this medication cause a birth defect and decrease IQ following in utero exposure. So please remember, it's not allowed totally absolute contraindication during pregnancy valproic acid, because valproic acid highly risk of malformation, congenital malformation, teratogenic or fetotoxic. Okay, next medication for epilepsy, we have Ethosuximide, Zarontin. Ethosuximide, you can see it here available like a capsule and liquid or syrup for the children, and this one considered like first line therapy for absent seizure. So if this one considered like the first choice for the children suffer from absent seizure, Ethosuximide blocked T-type calcium channel. Ethosuximide block T-type calcium channel. This one available in the postsynaptic receptor. And if you like to remember, we have T-type here, we have Ethosuximide here. We have T in both of them. So Ethosuximide block T-type calcium channel in the postsynaptic, postganglionic neurons, and consider first drug treatment for the children suffer from absent seizure, and consider this medication considered the least toxic anti-epileptic medication. Okay, phenobarbital. Phenobarbital work on GABA A, and phenobarbital work on different mechanism. Work on GABA A, but by prolonged opening duration of chloride channels. So we have chloride channels, and we have the GABA here. This is a chloride channel, and we have phenobarbital. Here we have benzodiazepine. Phenobarbital, when the phenobarbital bind to the receptor, okay, this will lead to the open chloride channel and allow chloride to enter the cells. So you can see the negative ion there, and this will cause a case of hyperpolarization. And that means we are speaking about induced sleeping, hypnosis, reduced anxiety, and relaxation. And we have a hypnotic effect, so we have so many effects. The same situation for benzodiazepine, but here we need to remember phenobarbital prolonged opening chloride channel in the GABA receptor. Okay, the same situation, phenobarbital induced metabolism. If you go to the slide there again, so you can see here what we have. Phenytoin, carbamazepine, you can add to the list here, speak about so phenytoin, carbamazepine. What we have here, we can add here phenobarbital. Also, all these three medication induce metabolism. Okay, you can see here that what we have: induced metabolism, folic acid, increased risk of megaloblastic anemia, phenobarbital teratogenic, is not allowed to use during pregnancy, and this is considered during pregnancy. Moving to the tolerance and dependence, this medication may cause tolerance and dependence. The most important issue with the phenobarbital, if the patient take more than or equal 5 grams of the phenobarbital, the patient will die from the due to the central nervous system and respiratory depression. This is a toxic dose. So with the toxic dose, 5 gram or above, the patient will die due to the respiratory depression. And another important issue here for the phenobarbital with the toxic dose, we don't have antidote. Okay, we don't have something to reverse the action of phenobarbital. Okay, moving to the next group of medication, we have diazepam, lorazepam, belong to the benzodiazepine. We have diazepam, lorazepam available intravenous. We have midazolam available like intramuscular. You can prescribe it to the patient outside of the hospital, but if you have patient in the hospital or emergency room, we have midazolam, diazepam, lorazepam. Diazepam, lorazepam IV in the hospital emergency room. We have midazolam for IM for outpatient clinic, for example. So the midazolam injection, we use it for status epilepticus. As you can see here, we can use it for patients suffer from febrile convulsions in children, first-line therapy and safe medication. Diazepam may cause drowsiness, lethargy, physical dependence, memory disturbances. For this reason here, we don't recommend to use the diazepam in absence seizure, because this one will affect the memory in the children. More details we are going to cover with the next maybe topics about anxiety, hypnotic. But if you go back to the slide here, okay, this slide here we discuss that phenobarbital bind to the GABA receptor, and opening and prolong opening chloride channel. Phenobarbital. What happened with the benzodiazepine? Benzodiazepine binding to the benzodiazepine receptor, and this will lead to the increased frequency of the channel, open and close. So you can see here, benzodiazepine considered like GABA receptor agonist and increased frequency of opening channels. So we need to be familiar now between the increased duration, prolonged duration of opening channels with the phenobarbital, and with the benzodiazepine increased frequency of opening channel. Okay, we have case study here. I'm going to, for example, use the red color, stay in the red color. We have a 5-year-old boy present to the emergency department with a recurrent generalized tonic-clonic seizure here over 24-hour combined with a high fever and flu-like symptoms. What is the mechanism of action, the most appropriate medication for this febrile convulsions? So the patient suffers from epilepsy due to the high fever. Number 1, stimulate presynaptic calcium channel. VG stands for voltage gated calcium channel. Stimulate. Number 2, stimulation and inhibition. So if you stimulate a calcium channel in the presynaptic, this will stimulate the brain. This will stimulate the brain and may cause or may aggravate or make the situation worse. For this reason, this is not correct answer. We need something to inhibit, not stimulate. Stimulate sodium channel. It's not correct, because if you stimulate sodium channel, this will stimulate the brain also. We're looking for something to inhibit and relax the brain. Stimulate postsynaptic chloride influx. Okay, so I will keep it C for later. Inhibition of presynaptic neurotransmitter reuptake. So if you talk about the stimulation of postsynaptic chloride channel, because when the chloride enters the cells, this will cause hyperpolarization and lead to the abort the convulsions and treat of convulsions in this patient. And benzodiazepine, one of the most important group of medication. If you go back there, we have diazepam and lorazepam available IV. So what about the last one here with the D option here? Option D, inhibition of presynaptic neurotransmitter uptake or reuptake. This one, if you are talking about glutamate, okay, and you inhibit the reuptake, the result will be activate the brain. This is not correct. Okay. Okay, moving to the next medication, vigabatrin. As you can see here for vigabatrin, okay, for vigabatrin here, vigabatrin work on the transaminase, GABA transaminase, inhibit GABA transaminase, okay, and increase level of GABA. And I need to go to the slide again. Okay, this is vigabatrin. Vigabatrin block the transaminase, GABA transaminase. Okay, here we maybe we need to go a little bit to the pathophysiology or the physiology, what happened with the GABA. When you have the neurons, if you remember, we have the neurons. This is a glutamate neuron. And then we have the postsynaptic, also here we have, this is postsynaptic neuron, presynaptic neuron, and this is a glutamate receptor. And then we have on the others, okay, this is represent GABA neurons. Okay, if you go to the blue color here, the GABA will be released, bind to the GABA receptor here, GABA receptor. Then we have the reuptake, another one, and another one we have transaminase, GABA T. Okay, so we have three pathway for the GABA. So if you go, maybe summarize that, so you can have it like this: GABA bind to the postsynaptic receptor and cause the effectiveness or efficacy. Effectiveness, number one. Number two, GABA could be returned back and reuptake. Okay, number three, could be metabolized by the transaminase. So we have three pathways, as you can see here. So vigabatrin, our medication here, vigabatrin, inhibit transaminase. So the vigabatrin inhibit transaminase. So what happened here, when you inhibit transaminase, this will lead to the enhanced efficacy of the postsynaptic. So you can imagine you have a river with the two branches, for example, here, and your medication, river with the two branches, and one of the medication block this branch, and the situation will be enhanced activity of this branch here. The same situation apply when you use something to inhibit transaminase. We have vigabatrin inhibit the transaminase. This will activate the postsynaptic receptor and lead to the opening chloride channel, hyperpolarization, and relaxation. Okay, the issue here, big issue here with the vigabatrin may cause permanent visual loss around 50% of patient. This is permanent, irreversible visual loss, and we don't prefer to use it. This one could be like reserve therapy. We use it for the patients from refractory complex partial seizure, focal seizure. So it's not first choice. Vigabatrin, Sabril, used for patients from refractory partial seizure. Could be used for patients from infantile spasm in children with a syndrome called West syndrome. So infantile spasm or West syndrome, we can use vigabatrin, but what the drawback or adverse drug reaction, this medication causes visual loss in 40% of patients. So the question, which of the following anti-epileptic drugs may cause visual loss? And this medication used for patients from infantile spasm. This medication causes withdrawal effect, somnolence, somnolence, fatigue, neurotoxicity, anemia, and weight gain. Okay, so if you keep a new weight gain in consideration, this will be maybe important for the next slide, because we have some medication decrease weight. So Vigabatrin associated with the increased weight. Vigabatrin, if you prescribe Vigabatrin to your patient Sabril, so you recommend to do the visual test every 6 months. Okay, Lamictal or Lamotrigine. Lamotrigine, Lamictal work on two mechanisms: block sodium channel and inhibit release of glutamate. Lamotrigine, Lamictal, its benefit for all type of seizure, could be used for bipolar disorders. Lamotrigine could cause hypersensitivity, multi-organ hypersensitivity, Dress syndrome, Stevens-Johnson syndrome. Lamotrigine, so we need to remember this one. Lamotrigine may cause neutropenia, thrombocytopenia, pancytopenia, with the penia mean decrease. So decreased number of white blood cells, decreased number of platelet, thrombocytopenia. Patient suffer from Stevens-Johnson syndrome. Some patient may come to the emergency room suffer from a septic meningitis. Okay, and the most important takeaway point here for the Lamotrigine. Lamotrigine considered one of the most important medication during pregnancy. We can prescribe it safely to the pregnant woman suffer from epilepsy. So the keyword, two keywords here. Lamotrigine may cause skin rash, Stevens-Johnson syndrome. Lamotrigine preferred agent during pregnancy. Okay, if you click at the link here, they give you a lot of information about Lamotrigine. So you can see the black box warning for Lamotrigine, for example, here. So you can see the recommendation here. Cases of life-threatening serious rashes, including Stevens-Johnson and toxic epidermal necrosis. So this one associated with the Lamotrigine. Okay, Lamotrigine, two things: Stevens-Johnson and safe during pregnancy. Topiramate, Topamax. Topiramate, Topamax, we have the generic name, block sodium channel, increase GABA, block AMPA kinase receptor. So multiplicity of action, multiplicity of receptor affected by Topiramate. Topiramate used for all type of seizure, focal and generalized. Topiramate used for migraine prophylaxis. So if you go back to the slide with the migraine, you can see the Topiramate anti-epileptic drugs used for prophylaxis of migraine. Migraine may involve in kidney stone, suicidal thought, metabolic acidosis, hyperthermia, fetal toxicity, encephalopathy, anorexia. Here, if you look what we have, weight loss. So if you go to Vigabatrin cause weight gain. If you go to the Topiramate cause weight loss. So which of these medication belong to the anti-epileptic drugs associated with the anorexia and weight loss more than 5% of patients? Okay, we have Topiramate, Topamax. Which of these medication used for anti-epileptic medication used for migraine prophylaxis? Topiramate. Which of these medication used for epilepsy but may cause kidney stone? Topiramate. Okay. Then we move to the next medication. We have Levetiracetam, Keppra. Levetiracetam, and this medication work on the specific type of protein on the glutamate receptor. Specific type on the glutamate receptor, and this is a specific type of protein called synaptic vesicles protein. I recommend you to go to the first slide for this lecture here or the lecture before, and look what we have in the vesicles. We have the granules inside the glutamate receptor. Here we have protein called the SV2A, this protein here, and Levetiracetam, Keppra bind to this protein. So Levetiracetam, very specific medication work on the specific type of protein. For this reason, this medication could be used in children above 12 years if they suffer from myoclonic seizure, or 6 years if they suffer from tonic-clonic seizure. So we can use it for myoclonic or tonic-clonic seizure. Number one, this medication may associate with the suicidal behavior, ideation, asthenia, ataxia, anaphylaxis, angioedema, serious dermatological reactions, increased risk of epilepsy. If you stop this medication rapidly, recommend to stop this medication gradually. This medication carry the risk of increased blood pressure. That's fine. But what about the psychotic syndromes? Patient may suffer from depression or anxiety. So levetiracetam, Keppra, increased risk of depression and anxiety, suicidal thought, and this is the disadvantage of Keppra. But what is the advantage of Keppra, levetiracetam? The advantage, okay, no drug-drug interaction. You can prescribe it to the patient, no risk of drug-drug interaction. Number one, this medication, very specific medication, work on the SV2A and the synaptic vesicles. Okay, but the drawback, maybe the negative effect, this medication increased blood pressure, cause psychotic symptoms. Okay, then they move there, they try to improve that levetiracetam, and they bring something brivaracetam, Brivaracetam, available tablet, oral or IV, oral solution or IV, brivaracetam. It's like analog of second generation of levetiracetam. Second generation from levetiracetam. FDA approved 2016 for focal seizure. What else? We can use brivaracetam for patient as young as 1 month of age. So we can use it early, maybe age of development, 1 month of age. That's great. Any advantages? Brivaracetam compared with the levetiracetam? Yes. Number one, Keppra, levetiracetam, less expensive. Briviact or brivaracetam, more expensive. What else? They said this medication cause psychiatric or psychotic effect, more psychiatric effect. Okay, what about here? Less psychiatric effect. Okay, depression, suicidal, anxiety, less, more expensive. What else? This medication metabolized with the Keppra, there's minimum effect on the liver. So we have no effect, no drug-drug interaction. Okay, what about here? We have drug-drug interaction on the liver side. So Keppra, the advantage of Keppra, no drug-drug interaction compared with the brivaracetam. I will go back and show you what we have. So levetiracetam carry the advantage of no drug-drug interaction. If you compare that with the brivaracetam carry the risk of drug-drug interaction. Again, for the brivaracetam, the second generation, as we discussed that, considered like second generation of levetiracetam, Keppra, well tolerated, could be used for children age 1 month and older, used for tonic-clonic and generalized epilepsy. IV form could be used for status epilepticus. The advantage also for the brivaracetam, no need to adjust the dose in patient with the renal, so no need to adjust the dose in patient with the mild to severe impairment of renal function, but we need to adjust the dose if the patients are from renal failure. Okay, brivaracetam, less psychiatric effect here, only the highlight. We need you to remember the highlight. How to switch, for example, levetiracetam, you can switch directly from levetiracetam to brivaracetam. We can move the patient from 2 with a ratio 1 to 10. For example, we can prescribe 100 milligram, 1000 milligram levetiracetam equal to the 100 milligram of brivaracetam. So in this case, we can call the brivaracetam is like more potent 10 times, brivaracetam more potent 10 times than levetiracetam. Okay. Adjuvant drugs, we have gabapentin, pregabalin, work on the alpha 2 delta 1 subunit on the calcium channel, and this will lead to the decreased release of glutamate. Could be used for focal seizure, neuropathic pain, post-herpetic neuralgia, fibromyalgia. So all these medication, but you can see here weight gain again. So which of the following medication, anti-epileptic medication, may cause weight gain? We have gabapentin, pregabalin, and figabatrin. Okay, so tiagabin work on the reuptake, inhibit reuptake. If you remember, we have a transporter, and we call this transporter GAT, GA, GABA transporter. Tiagabin inhibit reuptake of, this will lead to the increased GABA concentration. Okay, so what we have here, we have some article for pharmacology and mechanism of action of pregabalin, the calcium channel alpha 2 delta on the subunit, and this one available in the presynaptic. Please remember that. Presynaptic neurons. Okay, during pregnancy, what type of medication during pregnancy we need to prescribe? You can see here the reason we don't like to prescribe phenobarbital, phenytoin, carbamazepine, the risk because they consider like D during pregnancy, like teratogenic, spina bifida, and cleft palate. It's like this number one. Number two, so we have the maybe birth defect. Number two, this medication increase the pregnancy case, increase clearance of this medication, and decrease efficacy of this medication. Okay, so the pregnancy increase clearance of this medication and decrease efficacy of this medication for two reasons. Number one, this medication cause teratogenic effect, or consider like birth defect agents. This number one. Number two, the pregnancy accelerate metabolism of this medication. So we have two reasons we don't prescribe. Maybe give us the justification not to prescribe phenobarbital, phenytoin, or carbamazepine. The preferred agent, Lamotrigine, followed by Levetiracetam, preferred agent during pregnancy, and always advise the pregnant woman to take folic acid to minimize the risk of neural defect, neural tube defect. Okay, at the end of this lecture, I would like to summarize what we maybe mentioned in the beginning. Here we spoke about the individual drugs. We start with the Phenytoin, and we need to remember Phenytoin associated maybe with the gingival hyperplasia, lymphadenopathy, hirsutism. Phenytoin maybe considered like teratogenic agent. We don't recommend it to use it during pregnancy due to the birth defect. Moving to also we mentioned the drug-drug interaction between Phenytoin and other medication, because Phenytoin accelerate metabolism. The second medication was Carbamazepine. Carbamazepine also, we need to remember it's considered like teratogenic agent, Carbamazepine. And the most important spotlight or the keyword for the Carbamazepine, Tegretol, we can use it for patients from trigeminal neuralgia. Then we discussed the drug-drug interaction between carbamazepine and cytochrome inducers and cytochrome inhibitors. Moving to another medication, valproic acid, the Depakene, work with several mechanisms. Depakene could be used for all type of seizure, but we have very important high risk of teratogenic. We don't recommend it to use it like absolute contraindication during pregnancy, exit during pregnancy. We don't recommend to use it. Important side effect, alopecia, pancreatitis, hepatotoxicity, DRESS syndrome. Ethosuximide work on T-type calcium channel, used especially for the absence seizure and because of the least toxic. Then we move to the phenobarbital. Phenobarbital work on the GABA receptor by prolonged opening the chloride channels. Could be used for status epilepticus, could be used for patients from febrile fever in children. Teratogenic again for the phenobarbital. We need you to remember that with the phenobarbital we have toxic effect. The patient will die from phenobarbital. We don't have antidote from phenobarbital. Benzodiazepine work on the same receptor, work on the GABA receptor by increased frequency of opening GABA receptor. And we have diazepam, we have lorazepam available like IV, used for status epilepticus, midazolam available intramuscular IM, could be used for febrile epilepsy in children also. Moving to the vigabatrin work on the GABA transaminase. Vigabatrin associated with the visual loss around 40% of patients could be used, receive this medication for refractory epilepsy, not response to the other medication, and for West syndrome or infantile syndrome in the small young age. Lamotrigine, I like this name here, Lamotrigine. Lamotrigine work on sodium channel inhibit glutamate. All type of seizure could be used. Lamotrigine carry the risk of Stevens-Johnson syndrome, septic meningitis. Lamotrigine could be used safely in pregnancy, and this is the advantage of Lamotrigine. Moving to the Topiramate, I like Topiramate because Topiramate remind me with the obesity. Topiramate is a medication for obesity. Topiramate a medication for migraine prophylaxis. Topiramate is a medication for the epilepsy. So we can see here for the Topiramate. Topiramate cause kidney stone, fetal toxicity also. Moving to the Levetiracetam. Levetiracetam advantage, no drug-drug interaction with the liver enzyme, but levetiracetam associated with the psychotic symptoms. The alternative here we have in the market, we need to remember how the levetiracetam work on the specific type of protein on the synaptic and the glutamate synaptic vesicles called SV2A on the synaptic and decreased release of glutamate. The alternative we have brivaracetam. It could be used in young age, the similar situation, but it's like more potent, 10 times more potent than the levetiracetam Keppra. Less psychotic effect, but this medication is more expensive. Okay, so and this we are going to conclude our lecture today, and I hope everyone maybe enjoy and learn from this presentation and lectures about anti-epilepsy and anti-epileptic drugs. And the next one will be cover the migraine. And stay tuned and have a great day, everyone.